So may I now call upon Dr. Kunjan Kumar from Artikor Medical College. Are you going to present?
Yes.
What is your name, doctor?
Arif.
Dr. Arif from
Arif.
Artikor Medical College to present the case.
Good afternoon, respected teachers and my colleagues. Today I am going to present a case of left PUG obstruction with long upper ureteric stricture following failed dismembered pyeloplasty. My patient is a 27-year-old male presented with pain over left flank for 4 years and history of surgery for this condition 3 years back. 4 years back, patient was apparently well, then he developed insidious onset, intermittent, dull-aching, non-radiating pain over left flank. It was usually not associated with nausea or vomiting and usually was relieved with intake of some medicine. He had history of surgery for his condition and based on the evidence by his discharge paper, we found that he underwent open Anderson-Hines dismembered pyeloplasty in Artikor Medical College 3 years back. However, his symptoms reappeared just after 2 months of surgery and he continued to suffer from similar attacks of pain from 2 months after surgery. There was no associated history of hematuria, lower urinary tract symptom, pyuria, lithuria or any history suggestive of pyelonephritis. There was no history of tuberculosis or other significant disease. There was no other surgical history except pyeloplasty. There was no family history of tuberculosis or similar disease or other significant disease. Bile and bladder habits were normal. There was no history of any addiction. Now coming to clinical examination, the general survey was essentially normal with average build of the patient and good nutritional status of the patient. Now coming to systemic examination, in abdominal examination on inspection there was the scar of the previous surgery. It was a left flank scar and there is the inspection was otherwise normal and there was no any visible lump. The palpation, abdominal palpation was essentially normal and there was no palpable lump or any other abnormality found. Other systemic examinations were also with a normal limit. Now coming to investigation, routine blood investigations including renal function test was normal. Urine analysis was unremarkable and urine culture was sterile. Now coming to imaging, on ultrasonography we found grade 4 hydronephrosis in the left kidney with parenchymal thinning. However, the left ureter could not be delineated. Right kidney and visualized part of right ureter was normal. On CT scan, the left kidney was enlarged with gross hydronephrosis with narrowing at left PUJ. Left ureter was could not be delineated. Contrast uptake in left kidney was normal, but the excretion was delayed when compared with the right kidney. The right kidney and ureter was normal. DTPA renogram showed type 2 curve in the left kidney suggestive of renal outflow obstruction. The right kidney showed non-obstructive curve. Absolute GFR was of left kidney was 31% and split function 34 ml per minute and split function was 31%. Absolute GFR of right kidney was 76 ml per minute. Split function was 69%. So, with the diagnosis of recurrent left ureteric junction obstruction, we planned for RGP and proceed. Routine preoperative evaluations were done, but on table RGP, we saw that there is grossly dilated PCS tapered at PUJ and there is about 5 to 6 centimeter long upper ureteric stricture as evidenced by a thin stream of dye passing from upper ureter to the pelvic calyceal system. However, a guide wire could be negotiated till pelvic calyceal system. And we explored the patient and we managed the condition with only buccal mucosal graft ureteroplasty over a 6x26 DJ stent. The graft and the anastomotic area was covered with omental pedicle. Post-operatively, catheter was removed at 48 hours, drain was removed 48 hours later as the output was minimal. Patient was discharged on post-operative day 5 with healthy wound. Post-operative follow-up, DJ stent was removed After 4 weeks, on-table RGP again revealed no contrast leak and healthy ureteral caliber of the reconstructed part of the ureter. DTP renogram at 3 months after surgery showed non-obstructive curve with absolute GFR of 30 ml and the patient is free of symptom at 6 months and is under OPD based follow-up. 6 monthly OPD based follow-up. So now take home message: PUGO with long segment upper ureteric stricture pose difficult questions, and there are multiple options, but sometimes these are technically challenging, and in such different scenario, buccal mucosal onlay graft is an option with low morbidity and encouraging early results. Thank you.
So I have got one query. What are the causes of failed primary pyeloplasty?
Sir, it may be due to operative mistakes like if the mobilization is not proper and the unhealthy segment is not properly excised, then it will obviously lead to failed procedure. And if there is any crossing vessel and transposition is not done, then it may lead to recurrence. Or if there is urine leak that leads to periureteric adhesion, and that may also lead to failure in the surgery.
So technical fault, got water tightened, mass tension, less osmolality. These are the faults.
Yes, sir.
Huh?
Yes.
I was just wondering, you could have used a flap from the pelvis, it was very distended.
Yes, sir. During exploration, actually we didn't plan for buccal mucosal graft only repair, but after exploration we found dense adhesion surrounding the pelvis, and all the flap procedure requires clear dissection of the whole of the pelvis. Delineation of whole of the pelvis is required. So we couldn't proceed with those flap procedures, and then we go ahead with BMG.
The buccal mucosa is not the textbook teaching. So what are the other options?
Other options.
So if you are not in institution, suppose.
Based on book teaching, sir, there are flap procedures like Scardino prints and cupdioid spiral flap, and there is a renal descensus. We can go for renal descensus and
Difficult. Okay, then you should try. That will not solve your purpose. One is the flap procedure. Anything else?
sir, another is not done nowadays is Davis intubated ureterotomy. That is ureterotomy. Anything else, sir? We can, in very difficult situation, go for auto transplantation.
As you have seen in the WhatsApp group, Ritesh from this institute, he has done auto transplant in the loss of.
Anything less than auto transplant disease is very difficult.
Sir, iliac transposition. Iliac transposition.
You cannot get a flap and get a
Ideal flap, and you are talking of going to the moon.
What else?
Iliac transposition, sir.
Anything else?
Anything else?
See, my worry is you have put a buccal graft on a ischemic set. There must be a ischemic ureter. So buccal grafts do not generate vascularity. You have to have a very good vascular bed.
Yes, sir.
What is your explanation? You could have gone wrong. Is
Sir,
it okay?
Sir, we have covered the graft with omental pedicle, sir. Vascular
So you have the
omental
option,
pedicle.
see, you have the option,
Yes, sir.
ureterocalycostomy, then flap procedure, then ILL replacement, then decensus. As you have told, Davis intubated. So you have 5 other options also.
Yes, sir.
So at least in exam you cannot tell. You have to tell these options first, then
Others.
last buccal because I have seen.
The buccal mucosa, it's been done now, but you never know the Long-term
Actually,
problems.
buccal mucosa needs some support.
Yes, sir.
The long-term results are not
So
steady.
recently we have done 3 cases with young multi procedure results are good. Young multi,
That is different. But buccal mucosa needs some support which will give blood supply, as he is telling. Which will give imbibition and later on blood supply to this. You are not getting anything
Now it's
support.
for the momentum, whatever it's getting.
Just this nothing to prevent
They are doing
some
in the
leakage.
south now.
But not